The following program is a Town of Colonie television production of the William K. Sanford Town Library.
Welcome to the first episode of Mental Health Now. I'm your host, Matthew Shapiro, from the National Alliance on Mental Illness New York State, or NAMI as we're known. NAMI is the largest grassroots organization dedicated to providing support and education for people and families impacted by mental illness. We frequently say that NAMI is a place to provide help and provide hope, and that's what we hope to do here with Mental Health Now. This is so important as mental health impacts everybody. While 1 in 5 Americans will be diagnosed with a psychiatric disorder, mental health challenges are something all of us experience, whether they be depression, grief, anger, just to name a few. Too many people are still hesitant to discuss these issues, and that needs to stop, as communication is the key to generate the understanding necessary to end the stigma of mental health issues. And we're so grateful to the town of Colonie for giving us a vehicle to have these conversations with you. Our intention is to provide our viewers, whether you are someone with a mental illness, a mental health challenge, or a family member or a friend of someone with an issue, with education and support. And we'll also discuss some of the most vital advocacy issues needed to create a more mentally healthy New York State. We look forward to having guests who are truly leaders in improving mental health, both here in the capital region and throughout the state. So on that note, let me introduce our first guest. I'm so pleased to be joined by Bill Dickson, who's the Executive Director of the Capital District Psychiatric Center here in Albany. Welcome, Bill.
Thank you very much.
Oh, you're welcome. Thank you for being here. Let's start off with the basics. Can you explain the work conducted at the CDPC?
Sure. I'm always proud to speak about the Capital District Psychiatric Center. It's a state-operated psychiatric facility and psychiatric organization. One of the things that I think is important to appreciate about the range of services that CDPC provides is that it's a regional state psychiatric organization that serves a region as far north as Warren and Washington counties, as far south as Columbia and Greene, west to Schoharie, and east over to Rensselaer County and the 9 counties that are contiguous with there.
So Capital District in the broadest view.
Absolutely. And psychiatric facility in a broad view as well. In addition to being an inpatient hospital that serves at any given time upwards of 130 people on an inpatient basis, I know that there's so much more that we do. We're an adult inpatient facility. We also have adult outpatient services, both in Schenectady and Albany. We have 2 large clinics that serve nearly 1,000 people on an outpatient basis.
Wow.
And obviously that's an opportunity for people to continue their recovery long after any hospital stay, or maybe even before a hospital stay. And so we're proud of our services both in Schenectady and Albany in that regard. We do serve children on an outpatient basis as well. We don't have a kids inpatient service, but we do serve children and families in various spots across the region, again with outpatient clinics both on campus in Albany and also in Cohoes and in Glens Falls and Hudson Falls, which have been great community resources, and we've had great community partnerships in all of those spots. So that's been a great add to what we do as an organization.
Well, that's fantastic. Having community awareness is so important. And one of the things that also interests me about CDPC is that you operate 3 adult community residences. And can you explain how those are function, how they're different than inpatient stays?
Sure. Let me give a little bit more about what CDPC speaks and does across the region. We provide a unique crisis service in Albany County. We have a psychiatric emergency service, which is unusual for a state hospital to provide that level of care. Most counties have a community hospital that provides some of that psychiatric emergency care through a local emergency room in each of the counties in New York State. In Albany County, a lot of the psychiatric emergency services are run through our Capital District Psych Center.
So let me ask you, that brings up a good point. Too many of our families experience having to take a loved one to a regular emergency room at a hospital. For families here in the Capital Region, if you had a loved one who was experiencing a psychiatric emergency, you would advise to bring them to the Cdpc Emergency Center?
They're certainly welcome. We experience about 3,000 visits a year. Probably upwards of 400 children and families are among those 3,000 visits a year. It's a 24-hour, 7-day-a-week psychiatric emergency program. People are welcome from wherever they live. For expedience sake and for local competence and relevance, and there is a service in each person's home county, but again, people are welcome at our crisis service. It is a 24-hour program that's available to people when we're really at their toughest times, when they're concerned that any kind of community resource isn't going to be enough, and that the plans coming together are just not safe enough or stable enough without another professional opinion.
Yeah, and that's so vital. I mean, we hear horror stories all the time about someone bringing their loved one to an emergency room and they have to wait 24, 48 hours, there are no beds available, and that could be so traumatic to someone who's already experiencing a psychiatric emergency. So it's such an important service to have.
So inpatient care is difficult to access, as you describe, and so sometimes what happens is a person gets their emergency assessment and their emergency intervention completed, and then assuming, which is a broad assumption because many issues can be resolved on a less restrictive level than hospital, but assuming a person needs inpatient care, then the challenge becomes where are those beds available somewhere in the region, whether it's locally in our capital region that I described, which has a number of beds in each of the counties, or there are state inpatient beds, like I said, that Cdpc offers, and we certainly admit to our own facility as well.
Right, and that's always has always traditionally been a concern for NAMI and our families, is that there aren't enough beds, and so right now the state's kind of operating and reducing inpatient beds, as we discussed, and trying to transition people into community residencies. And as I mentioned before, Cdpc does operate 3 community residencies. So can you talk about the difference between that and inpatient stay?
Sure, absolutely. So residential care is very different. People have regained a great deal of freedom. There are people that are living a community-based life, an outpatient existence if they're following up with outpatient care, they choose to do that. Our residences, we have 3 community residential options in the Capital Region, with 2 in Albany, 1 on campus and 1 integrated in a community neighborhood of Albany, and we also have a community-based residence in Schenectady. All those residences are staffed 24 hours a day, 7 days a week, with professional mental health staff to support people that are in the early transitions of regaining their skills, regaining their integration in the community, reuniting with family, resuming their path towards education, employment, the skills that they've had in the past and expect to get back.
So it's almost like a step-down facility, someone coming out and
Yeah, it certainly can be. And there's plenty of residential options, kind of less intensive and less restrictive than even community residences that we operate. There's a number of levels of apartment living that have mental health supports available to them, and that's certainly another step or another place where a person can start their recovery back. A person needing to start from hospital and next go to another congregate care setting, they can certainly get back to an apartment if that's where their plan takes them and where their wishes are and their skill level suits them, then certainly they can move right to that.
Well, that's fantastic. And, we do want to see more community programs like that, because we do feel, of course it's such a broad spectrum, I'm going to get to that in a second, but people who can recover in the community, it's so beneficial, and, I think it's very helpful. But as we were discussing, so Cdpc, works with people with serious and persistent mental illnesses, and talked about how broad the spectrum can be. And I was hoping you can kind of elaborate on something we talk about a lot at NAMI, which is the difference between a person who's experiencing acute mental illness, a bout of depression or grief, or a mental health episode with mild psychiatric symptoms, and someone who has a serious and persistent mental illness. I think people kind of confuse it and don't understand the difference.
Yeah, I think it's great to highlight the kind of the spectrum of experiences that any of us can encounter on any given day. I certainly make that reference a lot to a lot of people on any given day. Any of us can experience, as you described in your opening, disturbances in our emotions, our thought processes, our behavior, and certainly those might suggest that there's some low-level emotional disturbance going on, some kind of psychiatric symptomatology that a person might be able to quickly manage, quickly rally some resources around, and kind of resume their day-to-day life. As symptoms become more significant, if the issues of emotional dysregulation or mental health processes, whether we're not thinking straight or we're experiencing thoughts that aren't kind of understood by others, if they're to the point where they're putting that person, really impacting that person's day-to-day function, it's becoming more difficult to maintain a family relationship. It's becoming more difficult to keep a work setting stable or a living situation stable, or if there's concerns that because of one's disturbances in emotions or thinking at any given time, is there a concern for dangerousness, which is far from the norm, and I applaud this show for educating people on a regular basis.
Right, of course, that's we talk about the stigma. Of course, that's one of the things that's such a misunderstood, is that people associate people with mental illness with violence. And we know that someone who is in treatment, taking medication, seeing a doctor, is much more likely to be the victim of a crime than a perpetrator of it. And it's so important that people understand that. We're in an interesting place right now where, we keep seeing this association. And, when the president, wanted to introduce $500 million for mental health care, which is a great thing. And of course, it's always welcome. It's so needed. But to have it tied in with violence, it kind of hurts the message a little bit.
I absolutely agree. And I think the more that there's public education through shows like this, through the advocacy that agencies like yourself lead the way with, I think that's more and more opportunities for all of us to recognize that either ourselves or someone we care about has experienced symptoms at some time in their life. And the vast majority of those folks, while experiencing those kind of difficulties, have never presented a danger to anyone.
Right. It's so important to understand. And, something we get talked about a lot in the mental health community now, it's like the key word is recovery. And obviously, recovery can be very different things for very different people. For some, recovery, like you said, is continuing your education and living independently. For some, recovery is getting out of bed in the morning and be able to communicate, shower, communicate with their family. So I'm just curious, roughly, what % of your patients with severe and persistent mental illness do you think can gain independence and live independently? I'm
strongly optimistic that the vast majority of people can regain that level of functioning and level of role in the community, in their family lives, and their work experiences. I know that there's many people that have experienced intense symptoms, intense areas or instances of self-harm, and have learned to manage those symptoms. I think, much like you would advise a family, you would advise a person experiencing any such symptoms to think about, first of all, I would say, how can that person feel like they're partnering with others? What kind of resources are available? Not to go it alone, whether you're the person experiencing the symptoms or you're the family, whether a loved one that's experiencing some difficulties. So I definitely think the vast majority of folks do recover and can recover. I think professional supports are key. I think family supports are key. Holistic approaches, the kind of the broader experience of wellness and managing someone's life and someone's broader health.
We look forward to having a whole show on that issue. It's something that NAMI has really embraced. And you kind of touched upon something that NAMI really embraces, which we firmly believe that the best recoveries happen when we establish what we call a recovery team, with the person who has the illness, their service care provider, and their family all working together in open communication. I think it's so important. But I think most family members want to help but don't know how. So people don't even know what the first step to take is when they believe someone might have a psychiatric ailment, whether it be a friend or a loved one, a family member. So what advice would you give family members who think they may have a loved one with a mental illness? And as we said, we discussed the broad spectrum. So maybe someone thinks they're a little depressed, or someone thinks it could be a more serious mental health issue. What kind of advice would you give those families?
Well, for starters, I would always suggest that you partner with the person that you're concerned about, that you hear from them what their impressions are about what's going on. Kind of break that ice from the beginning, not working through a person or beyond a person without seeing if there's an opportunity to partner with that person. And that's good advice to professionals as well, is that they find out how it is that they can adequately connect with a person who might be experiencing difficulties. And then also getting a sense from a person what matters to them. What is their hope and dream? What is their goal for their life, and how are current issues impacting that? See if there's any opportunity for insight there. For families, I would say you don't go it alone. Just like any other issue of trying to kind of better one's life or better the lives of people we care about, the better that we can build a circle of support, a support network, and best equip ourselves as the helper, whether it's by reaching out to family support groups, whether it's NAMI, whether it's family support services that are available across the region, whether it's by educating oneself, by reading a bit in the literature about, what is it that I'm looking at, what matters to people that are experiencing the kind of issues I'm encountering as a family member. And then there's also community mental health departments across the state and certainly across the country. They're always a good resource as a clearinghouse, kind of what's available in your local community.
Right.
And then at the most emergent levels, we've talked about like emergency services. There's more and more mobile services that are able to come out to communities and come out to families and loved ones, which is a nice alternative to kind of the institutional-based interventions of yesteryear and current. But there are a range of services at less intensive levels than hospital for sure.
Yeah, and that's very encouraging because, like I said, it can be so traumatic for both the family and the person who is experiencing the illness. I worked at NAMI for many years before I actually had to take my own mother who has mental illness to an emergency room in a regular hospital. And when that steel door slams, it's a very scary feeling for everybody. And, that's coming from someone who has a background. It's so important to have these less traumatic interventions.
Absolutely.
So it's wonderful. And I'm glad Cdpc offers that. Of course, like kind of touching on what I was talking about, being diagnosed with a mental illness can be scary, confusing, overwhelming, again, both for the family and the person who's being diagnosed. So what words of wisdom would you give individuals and families who are experiencing that wide gamut of emotions upon first receiving a diagnosis?
Well, first of all, I think what you're describing challenges the work we have to do to break down the stigma, because I think working first to break down the stigma nationwide, certainly locally, I would assume, from my family experiences and from others' experiences, that once we can kind of break down the mystification of a person experiencing any kind of emotional distress at any given time, it's ideally less frightening, less intimidating, less baffling, because at its core, a diagnosis is still kind of a label,
right?
And just trying to give a sense of what a person is experiencing, but you still want to kind of connect with the person and what matters to them. Where do they want to go with what's going on in their life?
And one thing we talk about a lot, a couple of things that you touched upon is, I think people still think words like schizophrenia, it sounds scary, Even, wasn't that long, 10, 15 years ago, that would almost be equated to like a death sentence. You couldn't have a productive life. And, obviously we do a lot of work with the NIMH and research, and we really believe in that. And the way they're looking at the diseases now, what we're calling schizophrenia now could be called 20 different things 10 years from now. So again, I think it's important that we look at the symptoms and not label someone. Like we say, labeling someone is for insurance purposes and Medicaid purposes so they can get billed correctly. But again, we have so many members and activists who have overcome their mental illness. And they said, my medication, my illness is not what defines me. My work what defines me. And I think it's very important for families to know. It goes to ending that stigma that, you hear schizophrenia, you still have all these associations that aren't accurate anymore. And
that may give a starting point for a conversation. It may give a sense of what a person is experiencing. It may not, because it may not be the most accurate depiction of a person anyway. But from there, then where do you want to go with that? I mean, and there's more and more programs developing statewide and nationwide for earlier intervention, for young people, both children and for young adults. Sometimes people are experiencing their most significant psychotic symptoms in early adulthood. And now there's more and more expert programs developing for people experiencing kind of that first episode of serious
Well, that's really the future. And well, the future is now in a way, which is good. And New York has really led the way in that with the On Track New York program, which kind of came out of the recovery after initial schizophrenic episode study that NIMH did and was conducted largely here in New York. And that's starting to spread all around New York State. OMH has really run with that, the Office of Mental Health. And it's exciting because it integrates so many things that NAMI feels is so
That's great.
important, involving family, encouraging continued education, employment. So
Right.
I think it's very important that we, like you say, get to it right at the beginning.
And that program is starting up in Albany as
Yes,
we speak. So, that's a
so
great
we're
thing.
very
Yeah.
excited about that. I know when we have Commissioner Sullivan on, we're going to be
Great.
talking about the program in
Excellent.
depth. So it's something we're very, very excited about. But that's it too, and we talk about this too. Mental health on college campuses is so underserved. A lot of times, like you said, that age group, it's really that 18 to 25 where those first psychotic symptoms present themselves. So we have a lot of work to do there too. But
I was just reading recently, though, that there seems to be a little bit of progress as far as kind of the destigmatization on college campuses, that more and more young people are more comfortable seeking help, continuing with their path to recovery, and not kind of falling prey to a diagnosis and the stigma that typically surrounds that. So that's a good sign.
Yeah, it's a very
certainly,
good sign.
Certainly we need more supports and more resources.
Well, it's an amazing thing, and I talk about this a lot. We have NAMI on campus clubs across the state, and I was brought out to Syracuse University and had a discussion, and you open the door for people. People are so willing to walk through and talk about it. People have been holding it so close inside and been afraid, and it was interesting because they actually had me present to the African American sorority and fraternity. And one of the gentlemen who got up and spoke told his story, and the girl who was actually the president of the NAMI-NYS chapter goes, "I know him well, and he's never discussed these issues. I'm shocked that he would discuss this." So I think once you enter the conversation, you see that these things can happen to anybody, that it takes, like you say, the stigma away, the fear away, and we can kind of have these conversations. Now, NAMI, you kind of touch on a bunch of things too, but NAMI offers a lot of programs for families. Our family support group, our family-to-family program, our peer-to-peer program. But like I said, I already gave you our belief about recovery is happening best when there's a recovery team. So I was wondering, what kind of programs does Cdpc have to involve family and provide the family support?
Sure. So we do have a family support services. We have a family support coordinator. He's a great advocate and a 24-hour resource to many families. I know you folks have met, and tremendous resource. I'm very proud of what we offer this region. I know that when word gets out, the region expands, so I know that we've been helpful to people across the country, quite honestly, and because mental illness doesn't stop at a county border, so we try to be helpful to anybody that needs that kind of support. But beyond that, Family Services Coordinator is a family support group that meets routinely in our facility. And that group of people who share a camaraderie, share a hopefulness, share strategies and recovery ideas about how they've managed either their own issues or supported their family members managing such issues has been a resource that brings me to tears pretty easily, but
it is. I mean, I've actually
very
participated in the stories you hear. I mean, what some of these families have gone through, and I almost hesitate to tell some of them because you don't want to instill that fear. That one person's story is not everyone's story, but what these people have experienced is really
and the recovery on the other end is just phenomenal. Just the way that people come out the other end, and particularly when they haven't experienced isolation along the way. Instead, they've experienced support, camaraderie, strategies, ideas, navigating the system, those kind of things. It goes so far, and so those are certainly ways that we incorporate the family role. We also, as treatment providers, both outpatient and inpatient, assume that everyone has some level of family support or a circle of support. There's some folks that may identify people beyond their family of origin as their family or their circle of support, and we really recognize the value of people identifying their family members, incorporating their family members, and building on the strengths that they can gain from staying connected to family.
We really appreciate that because that's so important. Something you hear a lot in NAMI too is that we make the comparison. When someone has cancer, the community runs towards them, but when they hear mental illness, the community runs away. And even within families, extended families, cousins, are afraid to get too close, and our families feel so isolated. So when you have a family support group or family to family, where families learn they're not alone, there's others that have this shared experience. And obviously we talk a lot about how a lot of these severe mental illnesses are biological, but and you can't catch them in it. But, I definitely think the families, I joke sometimes and say they are contagious in a way, because in caring for someone with any type of chronic illness, it's going to impact your own mental health, whether it be psychiatric or a medical illness. That chronic illness is always those ebbs and flows, and it's hard to be a caregiver, and giving them as many supports as possible is so vital. And someone doesn't have to have a loved one within the Cdpc system to attend. So I'm going to give a little plug. Your family support groups meets on Thursdays at 5:30, I believe.
I believe so, yeah.
Yep, at the Cdpc campus on New Scotland. In fact, in my plugs later, I'll actually be at one of those events next Thursday, February 4th. Excellent. So yeah, they do great work.
Great. And then the other invaluable resource, just to give them a plug also, is that more and more people are recognizing, like any other recovery process, that the value of connecting with other people with lived experience is tremendous. And so more and more people are taking on both a volunteer and a professional role as peer specialists, peer advocates, peer navigators, people who have walked the walk and now can talk the talk and can share the hopefulness and the example of recovery. And so peer advocacy is another show topic for you.
Well, yeah, and it's an amazing thing, and we've seen it so many times firsthand within our own NAMI family. Our greater NAMI family, that we have so many people who started in our peer programs, and that gave them the kind of the wind beneath their wings, so to speak. In fact, one of our greatest peer advocates, his name is Hakeem Rahim. Just last week, he testified before the U.S. Senate. I mean, he was someone who was severely, severely psychotic, thought he was talking to Jesus on the street, and this is while he was attending Harvard University. But through family support, through treatment, he's really shown what that recovery is possible. And I think, again, you touched on it so well, that people think maybe someone who has like depression or not as serious of a mental illness can recover, but someone that with a serious mental illness such as bipolar, schizophrenia, borderline, that recovery for them is not possible. But we know that's not true, and we have to give both the people and the families the tools to recover. And we're kind of touching, a lot has changed, and that's certainly good. There's more information, there's more hope, and as we talk about NAMI, find hope. But obviously there's still many questions that exist about the brain and psychiatric disorders. But in your opinion, what do you think's been the most impactful change, or generating a positive outcomes for people with mental illness?
I would think that among the most positive changes are really just breaking down the stigma, the barriers of isolation, the barriers of misunderstanding. The more that we can educate ourselves, the general public, families, people experiencing symptoms, experiencing struggles, the more that we can recognize, acknowledge that there's really much hope, much expertise, many resources out there, and that no one needs to feel discouraged or hopeless.
Yes.
And that there are plenty of resources out there and plenty of ways and roads to recovery.
Well, that's true. There's so many different roads to recovery. And those roads are never really straight, but so we all have a lot of work to do. And we hope that our viewers do join us on Mental Health Now to travel that road together. So we're almost out of time for today. So thanks so much, Bill, for joining us and being our first guest. And before I wrap, I just have a few quick announcements. Like I said, I'm actually going to be participating in two advocacy discussions coming up in the Capital Region. On February 4th, I'm going to be at the Family Support Group at Cdpc, beginning at 5:30. On February 17th, I'll be at the Family Support Group at Ellis Hospital in Schenectady, which begins at 6. And like we said, these are good opportunities to learn about advocacy issues, but also these groups do provide excellent support to families. That's so important. I mentioned our Family to Family course, which is a free 12-week course that we offer to teach families about supporting a loved one with a mental illness. And we're going to be starting one on February 8th at Samaritan Hospital in Troy. We encourage people to participate in that. And then on February 23rd, NAMI New York State is going to be hosting our annual Legislative Advocacy Day at the Albany Room in Empire State Plaza. So we encourage you to participate in that too. And if you have any questions about any of these events, please visit our website at www.NAMI-NYS.org or call us at 518-462-2000. And be sure to join us for our next episode, which is where we're going to be honored to have OMH Commissioner Dr. Anne-Marie Sullivan join us to discuss about some of the big initiatives happening in New York. Until then, We hope you all take care of yourselves, and remember, when creating a more mentally healthy community, hope starts with you. Thank you for joining us.